Welcome to the Deep Dive. Today we're taking a serious plunge into something critical for anyone managing patients with abdominal aorto-iliac artery aneurysms. We're unpacking the brand new 2024 European Society for Vascular Surgery, or ESVS, guidelines. These are comprehensive, they're packed with data, and our mission really is to navigate this wealth of information to pull out the most crucial practice-changing insights you need right now.
And you're right, they are incredibly comprehensive. The Guideline Committee incorporated a truly massive volume of new research just in the last few years, between 2019 and 2023. We're talking about over 474 new references. That includes 17 randomized controlled trials or their secondary analyses, 106 systematic reviews and meta-analyses, and 84 studies from vascular registries or quality initiative programs. It's a significant effort, to bring the evidence up to date.
Well, absorbing that much new literature that's a task in itself.
Right. It is. But here's where it gets particularly insightful, and perhaps for some, a little surprising. Despite this huge volume of new data being integrated, the guidelines really emphasize the persistent, weak state of evidence across many areas in the aortic field. When you look at the recommendations, only about 6%, that's just 10 out of 160 total recommendations, are actually based on level A evidence, which comes from multiple high-quality randomized trials. And a striking 70%, 112 recommendations, are still based on level C evidence or consensus among experts.
70% based on level C, or expert consensus. That's a powerful reminder, isn't it? It really underscores how much of what we do is still guided by, expert opinion and lower-level evidence. Even with all this research, it makes understanding the strength of the evidence behind each recommendation absolutely crucial for us in practice.
Absolutely, and the guidelines are very clear about this. They use a modified grading system from the European Society of Cardiology. You have Class 1 recommendations, where there's strong evidence and broad agreement that a treatment is beneficial and it is recommended. Class 2A means the evidence and expert opinion favor a treatment, so it should be considered. Class 2B indicates the usefulness is less established, it may be considered. And Class 3 is where the evidence or agreement suggests a treatment is not beneficial and is not recommended.
Got it. So Class 1 is a strong do this, 2A is consider doing this, 2B is maybe consider this, and Class 3 is don't do this. And then the evidence level tells you how confident we can be in that recommendation. Level A, based on multiple randomized trials or meta-analyses. Level B, from a single randomized trial or large non-randomized studies. And Level C, which is from smaller studies, observational data, case series, or simply expert opinion. It sounds like the Guideline Committee really prioritized higher levels of evidence based on that pyramid principle when deciding what to include from those 474 references.
Precisely.
Yeah.
They focused on peer-reviewed publications, weighting randomized trials and meta-analyses highest, moving down to observational studies and audits, and excluding things like case reports and abstracts.
That framework makes sense. And you mentioned the patient perspective being included.
Yes, it's a notable step. The guidelines underwent a lay review process, including input from patient representatives. This highlights the increasing recognition of the importance of shared decision-making, a theme we'll definitely see woven throughout. Our goal today is to dive deep into these updates, understanding not just what the recommendations are, but the evidence supporting them or, the lack thereof, and crucially, what that means for your day-to-day clinical work.
Okay, let's unpack it. Where do we start?
Let's start with the foundations, service standards and quality control. The guidelines place a strong emphasis on this, reflecting the need for high-quality care delivery. A significant new development is the definition of a core outcome set, or COS, specifically for elective abdominal aortic aneurysm repair.
A core outcome set. What does that entail exactly?
Right. It's a standardized set of patient-related outcome measures. This particular set was developed through a Europe-wide consensus process involving all the relevant stakeholders, including, importantly, patient representatives, which is key. It defines 6 essential outcomes that should be measured when evaluating the results of elective abdominal aortic aneurysm repair, helping standardize reporting and comparisons across centers and studies.
That's a great step for quality measurement. Moving to the practical side of service delivery, the guidelines updated the recommended minimum yearly caseload for centers performing standard abdominal aortic aneurysm repairs.
Right. Recognizing the relationship between volume and outcome, the recommended minimum is now upgraded to at least 30 procedures per year per center, and they specify how that breaks down. No less than 15 open repairs and 15 endovascular repairs. This acknowledges that competency in both approaches is important. They also added a new consensus recommendation for a minimum yearly caseload specifically for complex abdominal aortic aneurysm repairs, recognizing the distinct skills and resources required for those procedures.
So a clear minimum volume for standard cases, split between open and endovascular, and a separate consideration for complex cases. What's the evidence behind this volume-outcome relationship? This is pretty solid.
Oh, it's quite well established. For both elective and acute aortic repair, there's a clear link between the volume of procedures a center performs and the patient outcomes, including perioperative mortality, long-term survival, and complication rates. The guidelines cite large UK data analyzing over 31,000 procedures, which showed that hospitals performing a lower annual volume of procedures had higher 30-day emergency readmission rates and higher 30-day mortality rates after open repair. While surgeon volume is also associated with outcomes, modern practice increasingly relies on experienced teams, you see, making center volume a key indicator.
That makes sense. It's often about the whole team's experience, isn't it? Not just one individual surgeon.
Exactly. The guidelines discuss the role of surgeon specialty, with the writing committee strongly advocating for vascular surgeon leadership in abdominal aortic aneurysm care. However, they also acknowledge that excellent outcomes are achieved in multidisciplinary team settings, which often include interventional radiologists, particularly for endovascular procedures. They note, though, that there isn't a comparative study specifically evaluating outcomes based solely on whether the primary operator is a vascular surgeon versus an interventional radiologist when performing endovascular repair. It's a bit of a gap.
Right. That leads directly into training considerations, especially with the shift towards endovascular repair we've seen over the years.
It's a crucial point. The number of open abdominal aortic aneurysm repairs performed has significantly declined, with some reports showing an almost 80% drop in the U.S. over a decade. This reduction in open case volume naturally impacts the training opportunities and exposure for vascular surgery trainees. It's a real challenge.
Which is why simulation training is becoming so important now, I suppose.
Precisely. The guidelines strongly emphasize simulation-based training for both open and endovascular aortic repair techniques. This is formalized in Recommendation 5, which is a new recommendation in this version. The vascular surgery training curriculum should include simulation-based training in open and endovascular aortic repair. This carries a strong Class 1 recommendation, supported by Level B evidence, citing specific research on the effectiveness of simulation.
Class 1, Level B. That's a firm recommendation based on good evidence. They also suggest additional training approaches like rotations through higher volume centers, specifically for gaining open repair experience, and postgraduate fellowships in complex endovascular and open aortic surgery to ensure future generations have the expertise needed for those really challenging cases.
Absolutely. Investing in quality control, high-volume centers, and dedicated training programs are seen as fundamental to improving outcomes. It's all interconnected.
Okay, with that foundation set, let's talk about how we actually find these aneurysms and manage the patient's overall risk profile. That brings us to screening and cardiovascular risk factor management.
Right. The rationale for screening is compelling when you look at the natural history, particularly the risk of rupture. Rupture rates increase significantly as the aneurysm gets larger. The guidelines cite data showing annual rupture rates of 3.5% for aneurysms between 55 and 60 millimeters, rising to 4.1% for 61 to 70 millimeters, and 6.3% for those larger than 70 millimeters. More recent data looking at 3-year cumulative incidence rates in patients under surveillance painted an even starker picture for larger sizes. 2.2% for 50 to 60 millimeters, 6.0% for 61 to 70 millimeters, and a striking 18.4% for aneurysms over 70 millimeters.
An 18.4% chance of rupture over 3 years for something over 70 millimeters is, well, incredibly high.
It certainly highlights the urgency once they reach that size range. It's also important to note that rupture rates are generally higher in women than in men for aneurysms of the same size. Beyond the physical risk, the guidelines touch on the psychological burden of living with a large aneurysm, which seems to improve after successful treatment.
So finding them early seems logical to prevent rupture. But a major hurdle, and the guidelines really highlight this, is the inconsistency in measuring aneurysm diameter, especially with ultrasound. There's debate about where exactly to place the calipers methods, like inner to inner, outer to outer, and leading edge to leading edge.
And this isn't just academic, it has real clinical consequences. A recent systematic review confirmed that while measurement is consistent within a single observer, the variability between different observers using ultrasound is higher with certain methods. Critically, the choice of measurement method results in significantly different crude diameters. Inner-to-inner measurements are typically 3 to 6 millimeters smaller than outer-to-outer measurements.
3 to 6 millimeters. That difference could literally shift a patient from being below the treatment threshold to above it. That's quite significant.
Exactly. It has a major impact on the apparent prevalence of aneurysms in a screening program. Compared to inner measurements, using leading edge to leading edge can increase the prevalence by 31% and outer to outer by a remarkable 77%. The guidelines acknowledge there isn't clear evidence to strongly favor one method over the others, so consistency within a screening program is vital. But recognizing how your measurement method impacts the numbers both for diagnosis and follow-up is crucial. The guidelines point out that poor reporting standards, like not stating the plane or caliper position, significantly contribute to poor reproducibility.
Right. Consistency and being explicit about the method are key takeaways here. What about measurement using CT angiography or CTA? Is that more reliable?
Well, CTA is essential for detailed planning, diagnosis of rupture, and follow-up. But similar measurement challenges exist with CTA. Things like using axial versus orthogonal centerline measurements and variations linked to the cardiac cycle, while experienced observers using standardized methods can achieve reproducibility within the clinically accepted range of plus or minus 5 millimeters in about 90% of cases within their own readings.
Okay.
Reproducibility between different observers is poor. One study showed 87% of inter-observer comparisons were outside that 5 millimeter range.
87% variability beyond 5 millimeters between different radiologists. That's huge.
It means the number of patients classified as needing repair based on a diameter threshold could vary significantly depending on which radiologist reads. The scan studies show this could range from 11% to 24% of patients. It's a stark reminder that measurement isn't always as precise as we might assume.
So measurement itself is a recognized challenge. Despite that, what's the guideline's strong recommendation for screening?
The guidelines present Recommendation 11, which has been changed from the previous version. Ultrasound screening for the early detection of abdominal aortic aneurysm is recommended in high-risk populations to reduce death from aneurysm rupture. This carries a strong Class 1 recommendation supported by Level A evidence.
Class 1, Level A. That's its strongest possible recommendation based on the highest level of evidence. Screening in high-risk groups saves lives from rupture, basically.
Precisely. The asterisk flags that the definition of high-risk population needs to be tailored to local factors like prevalence in healthcare systems. Table 6 in the guidelines provides examples of potential high-risk categories to consider, including men aged 65 and older, current or former smokers, those with a family history of abdominal aortic aneurysm, or other peripheral aneurysms.
The guidelines also discuss the potential downsides of screening, right? Primarily the increase in elective repairs, which carry their own risks.
Yes, screening does roughly double the number of elective repairs performed. However, this is partially offset by a reduction in high-mortality emergency repairs. When you look at the numbers needed to screen 667 and the numbers needed to treat with elective repair just 1.5 to prevent one premature death from rupture, the benefit of screening in high-risk populations is clear.
Those numbers are quite compelling. And what about the psychological impact of just knowing you have an aneurysm and being under surveillance? Does that cause harm?
That's a good question. A recent review looked at health-related quality of life in screened patients and found no significant impact on quality of life from being under surveillance for a small aneurysm. So that potential harm seems less significant based on current data.
That's good to know. Cost effectiveness is also mentioned, confirming that screening remains cost-effective in countries with established programs, although falling prevalence in some areas might be challenging this.
Yes, prevalence is definitely a key factor in cost-effectiveness.
Okay, so screening is recommended for high-risk groups. What's the guidance on managing small abdominal aortic aneurysms detected by screening, the ones that aren't big enough for repair yet?
Studies like the UK's MAB-S trial, with long-term follow-up, and more recent cohorts like one from Sweden, provide valuable data here. MAB-S suggested that the benefit of screening might lessen over 8 years, with some late ruptures occurring in men who initially had very small subaneurysmal diameters between 25 and 29 millimeters. The Swedish study confirmed that a significant portion of these subaneurysms do progress. 30% of men with screen-detected subaneurysms in that size range progressed to the 55 millimeter repair threshold within 10 years.
30% progressing within a decade is substantial. That's not insignificant.
No, it justifies rescreening screening men with subaneurysmal diameters between 25 and 29 millimeters, provided they have a reasonable life expectancy. The recommendation is for a repeat ultrasound after 5 years. This group is small, less than 5% of screened men, so the resource impact of this follow-up is limited.
That makes sense, focusing follow-up on those most likely to progress to requiring intervention. What about deciding not to continue surveillance for patients who are very frail or elderly?
The guidelines suggest that surveillance of small aneurysms may not be necessary for patients unlikely to reach the repair threshold within a reasonable time frame, or for those who are simply unfit for repair due to significant comorbidities. For instance, elderly patients, say octogenarians, with aneurysms less than 40 millimeters are much less likely to either reach the threshold or be candidates for surgery. If you're considering discontinuing surveillance, shared decision-making with the patient is essential, ensuring they understand the situation. The guidelines also note that very few patients managed conservatively receive palliative care consultation, highlighting a potential gap in care for those not undergoing repair.
Shared decision-making, considering overall prognosis, and potentially palliative care for those not undergoing intervention are important points. Let's pivot to cardiovascular risk factor management. How does that intersect with abdominal aortic aneurysms?
This is a critical intersection. The ESC guidelines on cardiovascular disease prevention classify patients with an abdominal aortic aneurysm as having established atherosclerotic cardiovascular disease. This immediately places them in the high or very high cardiovascular risk category.
Meaning aggressive management of risk factors is paramount, right? Not just for the aneurysm, but for their overall survival.
Exactly. Recommendation 16, which is changed from the previous version, reinforces this. Quote, all patients with an abdominal aortic aneurysm should receive cardiovascular risk factor management with smoking cessation, blood pressure control, statin and antiplatelet therapy, and lifestyle advice, including exercise and healthy diet. This is a strong Class 1 recommendation supported by Level B evidence.
Class 1, Level B, a must do, based on good evidence. The asterisk points to the specific details being covered in dedicated cardiovascular prevention guidelines, I assume.
Correct. And here's a crucial clinical pearl highlighted by the guidelines. Despite these clear, strong recommendations, the actual prescription and patient compliance rates for things like statins and antiplatelets in abdominal aortic aneurysm, patients are disappointingly low, only around 60%. And over 30% of patients continue to smoke after being diagnosed, even though smoking is a major driver of aneurysm formation, growth, and rupture.
That's a significant gap between what we know patients need and what's actually happening. A diagnosis of an abdominal aortic aneurysm, maybe through screening, really presents a critical opportunity for aggressive secondary prevention, doesn't it?
It's a key teachable moment that we really need to capitalize on more effectively.
What about drug therapy specifically aimed at slowing down aneurysm growth itself? We've seen studies looking at things like doxycycline or telmisartan over the years. Any progress there?
The guidelines review the evidence from trials evaluating drugs like doxycycline, telmisartan, fenofibrate, and ticagrelor for their effect on aneurysm growth. The conclusion is clear and consistent across these studies. Currently, there is a lack of effective drug therapy proven to stop or significantly slow abdominal aortic aneurysm growth.
So while managing overall cardiovascular health is vital, there's no medication right now that will make the aneurysm itself shrink or stop growing. That covers screening and risk factors. Let's move to Section 3. The decision to repair. When do we pull the trigger based on diameter and patient fitness? This is the core question often.
It is a core clinical decision. The guidelines reiterate the strong evidence showing a very low rupture risk for aneurysms below 55 millimeters when measured by ultrasound. When translated to CT angiography, depending on the measurement method, this corresponds to roughly 55 to 62 millimeters.
And based on that low risk below 55 millimeters, the guidelines introduce a significant new strong negative recommendation.
Yes. Recommendation 20 is new. Men with an asymptomatic abdominal aortic aneurysm 55 millimeter are not recommended for elective repair. This carries the highest possible negative recommendation. Class 3, supported by Level A evidence.
Class 3, Level A. That means multiple high-quality randomized trials have shown is not beneficial and should not be done. It's as strong a recommendation against something as you can get.
Exactly. It firmly establishes that elective repair is not warranted for men below 55 millimeters. For women, the threshold is typically lower due to their smaller vessel size and potentially higher rupture risk at smaller diameters. Recommendation 21 is also new. Women with an asymptomatic abdominal aortic aneurysm 50 millimeter are not recommended for elective repair. This is a Class 3 recommendation based on Level C evidence, which is expert consensus in this case.
So a lower size limit for women, 50 millimeters, agreed upon by consensus, and a strong recommendation against repair below that size.
Correct. Now, the situation changes when we look at men with aneurysms 55 millimeters or larger. Recommendation 22 is changed. Men with an abdominal aortic aneurysm at 55 millimeters should be considered for elective repair. This is now graded as a Class 2A recommendation, supported by Level C evidence.
Class 2A, Level C, should be considered. This was a Class 1 recommendation in previous versions, wasn't it? Why the downgrade?
It was. The guidelines explain the nuance here. The randomized controlled trials like EVAR 1, DREAM, and OVER primarily showed that not operating on aneurysms below 55 millimeters is safe and doesn't worsen outcomes compared to early repair at smaller sizes. This evidence doesn't actually provide a strong trial-based threshold for when repair must take place. The decision to consider repair at 55 millimeters or larger is therefore based on observational data, risk modeling that shows increasing rupture risk above that size, and expert consensus leading to the Class 2A Level C grading.
Ah, that's a critical distinction. It's not that 55 millimeters is a magic number where the evidence says you must operate, but rather the point where the strong evidence against operating runs out. The guidelines consciously avoid calling 55 millimeters a strict threshold for this reason. That makes sense.
Precisely. It's the diameter where the discussion pivots from definitely not recommended to should be considered, integrating aneurysm size with patient-specific factors and shared decision-making. Providing patients with accurate information on the safety of surveillance for smaller aneurysms is important to reinforce the Class 3 recommendation against operating below 55 millimeters.
So considering repair at 55 millimeters or larger in men, and typically 50 millimeters or larger in women, is the guideline's position, but as part of a shared decision with the patient. What about patients who reach these diameter thresholds but are initially deemed too unfit for repair? What do we do then?
This is addressed in Recommendation 25, which is changed. Patients with an abdominal aortic aneurysm who have reached the diameter threshold for repair, but who initially are deemed unfit for repair, should be considered for continued surveillance, referral to other specialists for optimization of their fitness status, and then reassessment. This is a Class 2A recommendation based on Level C evidence.
Class 2A, Level C,
Yeah.
should be considered. So the message is don't just abandon them. Keep monitoring. Try to improve their medical status with input from other specialists, and then reevaluate if they become better candidates for intervention.
It's a pragmatic approach, recognizing that fitness isn't a static state and can sometimes be improved.
Okay, that clarifies the decision points. Let's move into Section 4, getting ready for elective repair, preoperative assessment, and intraoperative considerations. What's the focus here?
A major focus is preoperative risk assessment and optimization, particularly for cardiac and renal health. Cardiac complications are a leading cause of death after non-cardiac surgery, estimated to account for up to 42% of perioperative deaths. The guidelines recommend a stepwise approach to cardiac risk. First, aggressively screen for and manage active cardiovascular disease like unstable angina, decompensated heart failure, severe valve disease, or significant dysrhythmias. These require urgent assessment and treatment by cardiac specialists before you even think about abdominal aortic aneurysm repair.
So stabilize any acute cardiac problems first.
Absolutely. Exactly. Once active disease is ruled out or managed, you assess the patient's clinical risk factors and their functional capacity. Clinical risk factors include things like a history of coronary artery disease, heart failure, stroke or transient ischemic attack, renal dysfunction, diabetes, and their overall health status as measured by the American Society of Anesthesiology, or ASA, class 3 or 4, indicating significant systemic disease.
And functional capacity is assessed using metabolic equivalents, or METs. How does that work?
Yes, by assessing the patient's ability to perform daily activities. If a patient can perform moderate activities equivalent to METs 4 or greater, for example, climbing 2 flights of stairs without stopping, they generally don't require extensive further cardiac testing. However, if they have poor functional capacity, less than METs 4 or significant clinical risk factors, they should be referred for a formal cardiac workup to assess their risk and potentially optimize their condition further.
So assess active disease first, then use clinical risk factors and functional capacity, METs, to decide who needs more in-depth cardiac evaluation. How about renal risk? That's often a concern too.
It is. Patients with severe renal insufficiency, specifically chronic kidney disease, or CKD, stages 4 or 5, meaning an estimated glomerular filtration rate, or EGFR, less than 30 milliliters per minute per 1.73 meters squared, should absolutely be evaluated by a nephrologist before elective repair for optimization. Data suggests that for those with CKD stage 5, elective endovascular repair might only be considered for larger aneurysms, 70 millimeters or more, unless there are other pressing anatomical concerns, because these patients have a higher than expected one-year mortality rate even after successful repair.
That's a crucial piece of data for patients with severe kidney disease. A higher threshold might be appropriate there.
For patients with mild to moderate renal insufficiency, CKD stages 2 or 3, EGFR between 30 and 60, hydration is particularly important, especially if you're using intra-arterial contrast for imaging or during the procedure. The guidelines note a lack of clear, proven strategies beyond hydration for preventing post-operative acute kidney injury in these patients. Therefore, closely monitoring perioperative urine output is always recommended.
Hydration and monitoring urine output are key for patients with kidney issues. What about assessing nutritional status? Is that routinely done?
The guidelines suggest considering preoperative nutritional assessment, particularly by measuring serum albumin. An albumin level less than 2.8 grams per deciliter is presented as a potential threshold for considering preoperative nutritional support or correction. This is recommendation 35, which is changed, carrying a Class 2A recommendation based on Level C evidence.
Class 2A, Level C. Should be considered for assessing albumin and potentially correcting it below 2.8.
Okay, yes, suggesting it's a factor to consider based on lower-level evidence.
How about carotid artery assessment? We often see carotid disease in these patients due to shared risk factors, don't we?
It's common, yes, but the guidelines are clear. Current evidence does not support routine preoperative screening for asymptomatic carotid stenosis, nor does it support routine prophylactic carotid intervention for asymptomatic stenosis before abdominal aortic aneurysm repair. This aligns with the 2023 ESVS carotid guidelines, which give a Class 3 recommendation against routine screening or intervention in asymptomatic patients.
So don't routinely look for or fix asymptomatic carotid stenosis before fixing the abdominal aortic aneurysm.
Correct. However, there's a vital distinction. Patients with recently symptomatic internal carotid artery stenosis, meaning they've had a stroke or TIA in that carotid territory within the last 6 months, do require appropriate management of their carotid stenosis before proceeding with the abdominal aortic aneurysm repair. This is because performing surgery soon after a symptomatic carotid event carries a much higher stroke risk. This is consistent with the Class 1 recommendation in the carotid guidelines for revascularization before non-cardiac surgery in this specific scenario.
Okay, so if they've had recent symptoms from a carotid stenosis, that needs addressing first. But routine screening for asymptomatic disease is not recommended. Got it.
Exactly. You prioritize addressing acute or recently symptomatic issues.
Let's shift from preparing the patient to what happens in the operating room. Intraoperative considerations, starting with radioprotection during endovascular procedures. That's crucial.
This is absolutely non-negotiable. Anyone working with radiation during endovascular aortic repair must understand the risks to the patient from cumulative dose, risks to the operating personnel from scatter, and the potential for acute and chronic DNA damage in operators. Protective measures are essential. These include maximizing distance from the radiation source, utilizing shielding, lead aprons, thyroid shields, ceiling-mounted shields, strict collimation of the X-ray beam using pulse fluoroscopy instead of continuous, and considering advanced imaging techniques like image fusion overlay to reduce both radiation dose and contrast volume. The guidelines even suggest considering using a hybrid operating room with a fixed imaging system for high volumes.
Distance, shielding, smart imaging. Those are the fundamental principles of radioprotection. What about intraoperative cell salvage during open repair? Is that standard?
Recommendation 45 is unchanged. Intraoperative use of cell salvage and retransfusion should be considered during open abdominal aortic aneurysm repair. This has a Class 2A recommendation supported by Level B evidence.
Class 2A, Level B, should be considered for open repair to minimize the need for banked blood transfusions. And intraoperative heparin, always used.
Systemic heparinization is a standard principle in vascular surgery to reduce the risk of thrombosis during vessel clamping or stent graft deployment. Doses typically range from 50 to 100 international units per kilogram, administered before clamping or systemically before starting endovascular repair, although a systematic review found limited high-level evidence specifically for its efficacy in abdominal aortic aneurysm repair.
And using activated clotting time, or ACT, testing to guide the dose? Is that helpful?
The guidelines discuss the utility of ACT testing. Giving a fixed low dose like 5,000 international units might not achieve adequate anticoagulation and could risk thromboembolic complications. A weight-based dose of 100 international units per kilogram is more likely to achieve therapeutic levels. Monitoring with ACT, aiming for a target range around 200 to 220 seconds, helps ensure adequate anticoagulation while balancing the risk of bleeding. They mention the ongoing ASTION-1 trial, which is a randomized study comparing ACT-guided heparinization to a fixed dose during open repair, so more data coming, hopefully.
Okay, so ACT testing can help personalize the heparin dose. Finally, what about thromboprophylaxis after elective repair, preventing VTE?
Recommendation 48 is new. All patients undergoing elective abdominal aortic aneurysm repair and deemed at risk of postoperative venous thromboembolism should be considered for thromboprophylaxis. This is a Class 2A recommendation based on Level C evidence.
Class 2A, Level C. Should be considered for those at risk of blood clots in the veins after surgery. That covers the preoperative workup and intraoperative details. Let's move into Section 5. Elective repair, the choice of technique and device considerations. Open repair first.
For open surgical repair, the choice of graft material is discussed. Dacron, or polyethylene terephthalate, has been the workhorse for 70 years. Expanded polytetrafluoroethylene, or EPTFE, is also used. The guidelines state clearly there is no data suggesting superiority of one graft material over the other.
So, largely a matter of surgeon preference and familiarity. What about antimicrobial-coated grafts to potentially reduce infection risk? Are they recommended?
Recommendation 49 is new. For open abdominal aortic aneurysm repair, routine use of antimicrobial-coated grafts to prevent aortic graft infection is not recommended. This carries a Class 3 recommendation based on Level B evidence.
Class 3, Level B. A clear recommendation against routine use based on good evidence.
Yep.
Okay. What about the surgical incision for open repair midline, transverse, or retroperitoneal? Does it matter much?
The choice depends on factors like the extent of the aneurysm, patient body habitus, and surgeon preference. Midline is versatile. Transverse can be good for higher aneurysms. Retroperitoneal avoids operating through prior abdominal surgeries and is useful for complex or inflammatory aneurysms. The guidelines note that older studies were conflicting, but recent reviews and meta-analyses show no significant difference in major outcomes, including incisional hernia rates, between transverse versus vertical midline incisions, or between midline transperitoneal and retroperitoneal approaches for infrarenal repair.
So the incision choice doesn't seem to dictate major outcomes like hernias. It's more about technical access and patient factors.
Correct. However, the technique used to close the abdominal wall, particularly for midline incisions, is crucial. Incisional hernia is a common complication, reported in anywhere from 7 to 26% of patients after open repair. Risk factors include smoking, COPD, obesity, and the aneurysm repair itself.
How can we minimize that hernia risk? What's the recommended technique?
For midline incisions, the guidelines strongly emphasize closing the fascia using a specific technique. Small bites, meaning placing sutures close to the wound edge and ensuring the total suture length used is at least 4 times the length of the wound. That's a suture length to wound length ratio greater than 4.1. This technique has been shown to significantly reduce incisional hernia risk.
Small bites, high suture ratio. That's a key technical detail for closure. And what about using mesh prophylactically when closing a midline incision? Is that recommended now?
This is an area with a significant update. Recommendation 55 is changed and has been upgraded to a strong Class 2A recommendation, supported by Level A evidence. For open abdominal aortic aneurysm repair, prophylactic use of mesh reinforcement of midline laparotomies should be considered.
Upgraded to Class 2A, Level A. That's a major change based on solid evidence, suggesting prophylactic mesh during open repair is now something we should consider. That's quite definitive.
It's a direct impact of new trial data on the guidelines. Let's transition to endovascular aortic repair, or EVA. For arterial access, do you prefer percutaneous access or a surgical cut-down? What do the guidelines say? Recommendation 60 is changed, rephrased to. For endovascular abdominal aortic aneurysm repair, the choice of percutaneous access or cut-down should be considered based on patient factors and operator preferences.
So no strong preference from the guidelines. It's up to the surgeon.
Not a definitive one. They summarize a systematic review of randomized trials comparing the two. It found no significant difference in major complications. Percutaneous access might lead to fewer wound complications like seroma or lymphorrhea and could shorten procedure time by about 12 minutes, but the certainty of this evidence was low or very low. meaning the effect on clinically important outcomes is very uncertain.
So percutaneous access might offer some minor benefits, but the evidence isn't strong enough for a firm recommendation, leaving the choice to the surgeon based on patient anatomy and their own expertise.
Yeah.
Makes sense.
Exactly. Next, managing side branches, like accessory renal arteries. Are they important to preserve?
Yeah, I've always wondered about that.
Recommendation 62 is changed and upgraded to a Class 2A recommendation. For patients undergoing endovascular abdominal aortic aneurysm repair, preservation of large accessory renal arteries, 4 millimeters or larger, or those that supply a significant portion of the kidney, greater than 1/3, should be considered, however, without compromising adequate sealing.
Class 2A should be considered. So, if you can preserve an important accessory renal artery without jeopardizing the main graft seal, the guidelines suggest you should try.
Correct. What about the practice of routinely coiling side branches or doing a non-selective embolization of the aneurysm sac before deploying the stent graft? This was sometimes done to try and prevent type 2 endoleaks. Is that still recommended?
The guidelines specifically address this practice, don't they?
They do. Meta-analyses of studies looking at preemptive embolization found it was associated with lower rates of detecting type 2 endoleaks and reduced sac expansion. However, and this is critical for clinical practice, these studies found no significant difference in patient-centered outcomes like aneurysm-related mortality, overall mortality, aneurysm rupture, or the need for reintervention specifically for type 2 endoleaks.
No clinical benefit despite potentially reducing the type 2 endoleak rate. So it doesn't really change the important outcomes.
Precisely. The evidence certainty is low, and available data does not demonstrate a clinical benefit. Therefore, routine preemptive coiling or embolization of side branches or the sac for EVAR is not recommended.
Not recommended routinely.
Yeah.
Okay, device durability and the need for long-term follow-up have been major concerns recently, haven't they? Particularly with device recalls.
Absolutely. Events like the voluntary recall of the Valiant Navian thoracic stent graft due to late structural failures, and the issues leading to the failure and recall of the Nelix EVAS device, which prompted a specific ESVS-focused update recommending enhanced surveillance and considering explantation for affected patients, have put a real spotlight on device longevity.
These issues really underline the importance of rigorous evaluation of new technologies before they're widely adopted.
They do. The guidelines strongly advocate for using endovascular devices with proven long-term durability. They advise against using endovascular aortic repair outside the manufacturer's instructions for use, or IFU, in the elective setting. For newer devices, even if they're updated versions of established platforms, the guidelines recommend long-term follow-up in prospective registries with the stated increased requirement for 10 years of durability data before widespread adoption outside of studies.
10 years of durability data required even for updated devices. That's a significant push for more stringent evaluation, aligning with approaches like the FDA's. That seems sensible.
It represents a response to recent device issues and a desire for more robust proof of long-term safety and effectiveness before broad clinical use. The guidelines also briefly mention that factors like endograft oversizing may influence outcomes like migration and endoleak, though specific recommendations on oversizing are often device-dependent.
And what about brand new techniques like endosuture aneurysm repair or ESVAR, designed to treat challenging necks outside the standard IFU? Where do they stand?
Techniques like ESAR are currently considered unproven. The guidelines explicitly state they should be restricted to clinical trials at present. They mention the ongoing Socrates trial, a randomized study comparing ESAR to fenestrated EVAR for short neck aneurysms.
Limiting unproven techniques to clinical trials is formalized in a recommendation, correct?
Yes, recommendation 123 is unchanged. For patients with a complex abdominal aortic aneurysm, use of new techniques and concepts is not recommended in routine clinical practice and should be limited to studies approved by research ethics committees until adequately evaluated. This is a Class 3 recommendation based on Level C evidence and applies broadly to all near and unproven technologies in the aortic space.
And 3 Level C. Not recommended outside of clinical trials. Sticking to established techniques in routine practice. Got it. Finally, how do endovascular repair and open surgical repair compare for elective abdominal aortic aneurysm repair in the long term, based on the combined data from major randomized trials? What's the bottom line?
The pooled data from major randomized controlled trials like EVAR-1, DREAM, and OVER provide a pretty clear picture of the trade-offs. Endovascular repair has a clear and significant advantage in terms of lower 30-day operative mortality compared to open surgical repair. That's well established. However, this early survival benefit is lost in the long term. Looking at total mortality over the full follow-up period of the trials, there is no significant difference between the two groups. Crucially, aneurysm-related mortality is actually higher in the EVAR group after about 3 years.
Higher aneurysm-related mortality long-term after EVAR. That's a critical piece of information for patient counseling and follow-up, highlighting the need for ongoing surveillance after EVAR, isn't it?
It absolutely is a major trade-off. EVAR also leads to a higher rate of reinterventions compared to open repair. However, the guidelines point out that this difference in reintervention rates is less pronounced when you include the complications that require interventions after open surgical repair, such as incisional hernias and bowel obstructions, as was factored into the EVAR trial analysis.
So EVA reduces the immediate operative risk, but comes with a higher risk of late aneurysm-related complications and the need for more procedures down the line, although the total burden of reintervention might be more balanced when you count open repair complications. It's complex.
Exactly. It's a shift in the type and timing of complications. What about outcomes specifically in older patients, octogenarians, those 80 years and older? Is age alone a barrier to elective repair? Modern data from large registries and studies provide better insights into this population. They suggest that elective EVAR has a significantly lower 30-day mortality rate compared to open repair, specifically in low-risk elderly patients. While advanced age is a predictor of 30-day death, the guidelines emphasize that comorbidities are often more important drivers of mortality than age alone in adjusted analyses. Based on these modern data, the guidelines support considering elective endovascular repair in appropriately selected octogenarians who have a reasonable life expectancy and quality of life after a careful shared decision-making process that includes their preferences. Age alone should not be the sole reason to deny them treatment.
That's an important clarification. Age isn't an absolute cutoff. It's about overall fitness, life expectancy, and patient goals.
Good.
Precisely. Right, that covers elective repair. Let's move to Section 6. Managing the ruptured abdominal aortic aneurysm, the critical, life-threatening emergencies scenario.
Right. In the setting of a ruptured abdominal aortic aneurysm, most patients who manage to reach the hospital are stable enough to undergo a rapid computed tomography angiography scan. This is crucial to confirm the diagnosis and to quickly plan whether open surgical repair or endovascular repair is feasible. Hemodynamic instability, which would preclude this, is typically defined as loss or significantly reduced level of consciousness or a systolic blood pressure below 80 millimeters of mercury.
So if they're not an extremist, get the CT scan to guide the repair strategy. What's the critical decision point in a rupture EVAR versus OSR? What do the evidence favor?
This has been a major area of focus, and meta-analyses comparing the two approaches for ruptured abdominal aortic aneurysm consistently show that endovascular aortic repair is associated with decreased in-hospital mortality compared with open surgical repair. The benefit is particularly pronounced in hemodynamically unstable patients. One meta-analysis found mortality rates of 37% with EVAR versus 62% with open repair in this unstable group.
37% versus 62% mortality in unstable patients. That's a huge difference favoring EVAR if the anatomy allows. That's compelling.
It's why endovascular-first strategies have become standard practice in centers with the capability.
What about the type of anesthesia for ruptured EVAR? There's been discussion about local anesthesia versus general.
Local anesthesia, often combined with sedation, has gained significant traction for ruptured EVA. The idea is to avoid the potential for circulatory collapse that can occur with general anesthesia, and to potentially maintain some degree of peritoneal tamponade of the bleeding. While some operators may find it challenging due to patient discomfort or movement, meta-analyses have shown that EVAR performed under local anesthesia is associated with improved survival compared to general anesthesia. The benefit seems greatest in patients who are relatively stable. Pooled data showed perioperative mortality rates around 17.3% with local anesthesia versus 26.4% with general anesthesia.
So local anesthesia offers a potential survival advantage if the patient and team can manage it.
Yes. There's also a specific consideration if imaging was performed while the patient was in the state of permissive hypotension, meaning intentionally kept at a lower blood pressure during the initial resuscitation and imaging. Recommendation 76 is new. Patients undergoing endovascular repair for a ruptured abdominal aortic aneurysm in whom imaging was performed during permissive hypotension should be considered for stent graft oversizing of up to 30%. This is a Class 2A recommendation based on Level C evidence.
Why oversize up to 30% if imaged during low blood pressure? What's the rationale?
Imaging when the patient's blood pressure is low might underestimate the true normal size of the aorta. If you size the graft based on that hypertensive measurement, it might be too small once the patient is resuscitated and their blood pressure normalizes postoperatively, potentially leading to an inadequate seal. Oversizing helps account for this potential expansion and ensures a better seal at normal pressures.
That makes clinical sense, adjusting for the physiological state during imaging. What about specific complications in the ruptured setting, like aortocaval fistula or ACF? How do EVAR and OSR handle that?
Aortocaval fistula occurs when the rupture involves a direct communication between the aneurysm sac and the inferior vena cava. With open surgical repair, the surgeon directly closes the fistula from inside the aneurysm sac. With endovascular repair, the graft excludes the aneurysm, but the fistula itself, that direct connection between the sac and the cava, remains open.
And how does leaving the fistula open impact outcomes after EVAR?
A systematic review looking at endovascular repair for aortocaval fistula found higher rates of endoleak, often type 2, and more reinterventions compared to open surgical repair. Managing persistent fistulas after EVAR is still debated. Options include attempting embolization or stenting the vena cava if there are symptoms like heart failure or sac expansion, versus a more conservative approach if the patient is asymptomatic and the sac isn't growing. It's a bit of a tricky area.
So EVAR can fix the rupture, but might leave a long-term issue with the fistula itself. Another serious complication is postoperative colonic ischemia. How common is that?
This is a feared complication, and unfortunately it's more common after ruptured abdominal aortic aneurysm repair, with a pooled prevalence of about 10%. It's associated with significant mortality, causing death in roughly 4% of patients who develop it. The risk is higher after open surgical repair compared to endovascular repair, with a relative risk of 1.8 for open repair.
Is routine sigmoidoscopy recommended after ruptured repair to check for ischemia, or is it based on suspicion?
No. Routine sigmoidoscopy in all patients is not recommended. While it can help rule out ischemia, it's less specific for detecting clinically relevant transmural ischemia. Studies that perform routine sigmoidoscopy tend to report higher incidence rates because they identify milder cases. Instead, a selective approach is advocated, using sigmoidoscopy in patients where there is clinical suspicion or those at high risk.
So trust your clinical assessment first and use sigmoidoscopy if you're concerned.
Exactly. Close postoperative monitoring for signs of colonic ischemia is essential. If you suspect it, the guidelines suggest a diagnostic step-up algorithm, which is conceptually outlined in Figure 4. This involves frequent clinical reassessment, monitoring intra-abdominal pressure, or IAP, which correlates strongly with the severity of colonic ischemia, a low threshold for performing flexible sigmoidoscopy, and prompt exploratory laparotomy if needed to confirm transmural ischemia and manage it. Recommendation 84 is new. For patients undergoing open or endovascular treatment for ruptured abdominal aortic aneurysm in whom colonic ischemia is suspected, flexible sigmoidoscopy should be considered to confirm the diagnosis. This is a Class 2A recommendation based on Level B evidence.
Class 2A, Level B, should be considered if suspected, supported by good evidence. What about acute lower limb ischemia after ruptured repair? How often does that happen?
That's another potential complication related to access or perioperative factors. Data from large databases like the U.S. National Surgical Quality Improvement Program, or NSQIP, show an incidence around 4.8% after ruptured repair, with no significant difference reported between endovascular and open surgical approaches in that dataset.
Finally, managing ruptured abdominal aortic aneurysms, specifically in the elderly. We discussed elective repair in octogenarians, but what about rupture? Is age alone a reason to withhold treatment in that emergency setting?
Modern data is really challenging previous assumptions here. Data pooling outcomes for octogenarians with ruptured abdominal aortic aneurysm shows that while 30-day mortality is still high, around 43% in pooled data. Those who survive the initial 90 days have remarkably good long-term survival, exceeding 50% at 5 years, approaching the survival rate of the general population. Studies also indicate that while age is a factor in early mortality, more significant drivers are cardiac disease and manifest hypervolemic shock upon arrival.
And what about their functional recovery? Do they get back home?
Encouragingly, yes. A high percentage, over 80% in one study, returned to their pre-rupture home situation 1 year after repair. These data provide a basis for a more proactive approach to treating ruptured abdominal aortic aneurysms in appropriately selected elderly patients. Age alone should not be the sole criterion for denying potentially life-saving intervention.
That's a powerful message. Don't let age prejudice you against offering treatment if the patient otherwise has a chance. Important reminder.
Absolutely.
Okay, that covers the urgent world of ruptured aneurysms. Let's move to Section 7. Long-term follow-up and complications. What happens down the road after successful repair? What does survival look like?
Looking long-term, survival after elective abdominal aortic aneurysm repair is lower than that of the general population, hovering around 69% at 5 years, according to a meta-analysis of survivors. This highlights that these patients still have significant underlying health issues. Key predictors of late death after repair include age, sex, presence of comorbidities, especially end-stage renal disease, and severe COPD requiring supplementary oxygen, and the initial size of the aneurysm at presentation. Larger aneurysms are associated with higher late mortality and more secondary interventions.
So fixing the aneurysm doesn't fix all their problems. They're still at high risk from other things. Let's talk about specific long-term issues.
Yeah.
Thrombus formation inside stent grafts. How common is that, and is it serious?
This is something we see on follow-up imaging. It's been a concern as a potential source of late graft limb occlusions or embolization. It's identified in about 21% of patients within the first year, often linked to sharp changes in graft size or certain barrel shapes. However, studies to date have not shown an increased risk of clinically significant occlusion or thromboembolism associated with these asymptomatic thrombi.
So if you see asymptomatic thrombus in the graft lumen on surveillance imaging, no specific treatment is generally needed. Just watch it.
That's correct. For asymptomatic mural thrombus without significant flow compromise, no specific therapy is recommended based on Class 3 Level C evidence. However, Recommendation 89 is new. Patients treated by endovascular abdominal aortic aneurysm repair who present with symptomatic, evolving, or hemodynamically significant thrombus formation inside the stent graft may be considered for individualized intervention or escalation of antithrombotic therapy. This carries a Class 2B recommendation based on Level C evidence.
Class 2B, Level C, may be considered. So if the thrombus is causing symptoms, is clearly growing or obstructing flow, then you consider treating it, but not just for its presence alone. Okay.
Exactly. Moving to more serious late complications, aortic or stent graft infection, often referred to as AGI or SGI, and graft enteric fistula, or GEF.
These are among the most dreaded complications we face, aren't they?
They absolutely are. The incidence rates are concerning. For graft infection, it ranges from 0.3% to 6% after open surgical repair and 0.2% to 1% after endovascular repair. The risk of a graft eroding into the bowel, creating a graft enteric fistula, is reported between 0.3% and 4.3%, with a 2 to 4-fold higher risk after open repair compared to endovascular repair.
And managing these is extremely complex. What guidance do the guidelines offer? It must be tough.
Management is highly individualized and complex. For patients who require complete explantation of an infected graft or stent graft, Recommendation 92, which is new, offers an alternative approach. For patients undergoing complete explantation of an infected aortic graft or stent graft, extra anatomic reconstruction may be considered an alternative repair modality in frail patients, in cases with extensive infections or with graft enteric fistula. This is a Class 2A recommendation based on Level C evidence.
Class 2A Level C may be considered. So for challenging infection cases, especially in frail patients where an in-situ reconstruction might be too risky, bypassing the infected area with an extra anatomic graft, like an axillobifemoral bypass, is presented as a reasonable alternative.
Yes, acknowledging the difficulty of these cases. Now, let's talk extensively about endoleaks. These are perhaps the most common long-term issue we deal with after EVA, requiring lifelong surveillance.
They are a major concern, absolutely.
Exactly. Endoleaks are defined as persistent flow in the aneurysm sac outside the stent graft after endovascular repair. They can be identified in up to 1/3 of cases, depending on the type of imaging and how often it's performed. They are classified into types. Type 1, 2, 3, and 4, and can be primary, present immediately after the procedure, or secondary, developing later.
Which types are the most worrying? The ones we really need to act on?
Type 1 and Type 3 endoleaks are the most concerning because they allow arterial pressure and pulsatile flow directly back into the aneurysm sac. This pressurization carries a high risk of secondary rupture. In fact, Type 1 endoleak was reported in over 60% of ruptures that occurred after endovascular repair in one meta-analysis. Type 2 endoleaks, often from lumbar or inferior mesenteric arteries feeding back into the sac, are generally considered more benign but still require monitoring, especially if they cause the sac to enlarge. Type 4 endoleaks, related to graft porosity, are largely eliminated with modern devices.
So, Type 1 and 3 are high risk and usually need urgent treatment. Type 2 needs close monitoring and treatment if the sac grows.
Precisely. The guidelines emphasize the crucial importance of monitoring the sealing zones both proximally at the neck and distally in the iliac arteries, because changes like dilatation or migration over time can compromise the seal and lead to type 1 endoleaks. They suggest that even without a visible endoleak, you should consider preemptive treatment if the sealing zones show signs of becoming compromised. Don't wait for the leak necessarily.
And if the proximal seal specifically is compromised, what are the options then?
Recommendation 105 is new. For patients with a compromised proximal seal after endovascular abdominal aortic aneurysm repair, proximal extension with fenestrated and branched devices should be considered in preference to other endovascular techniques. This is a Class 2A recommendation based on Level C evidence. The asterisk defines compromised seal as inadequate seal length, less than 10 millimeters, or documented progressive neck dilatation.
Class 2A, Level C, should be considered. So, if the neck is failing, complex endovascular options like fenestrated or branched grafts are the preferred way to extend the seal over other endovascular approaches. What if complex endovascular is not an option or too risky?
Recommendation 106 is also new. For selected patients with a compromised proximal seal after endovascular abdominal aortic aneurysm repair, elective open conversion may be considered as an alternative to complex endovascular interventions, provided the surgical risk is acceptable. This carries a Class 2B recommendation based on Level C evidence.
Class 2B, Level C, may be considered. So for carefully selected patients who are fit enough for open surgery, converting to an open repair is a valid alternative if complex endovascular options aren't suitable or available for a failing proximal seal. Open conversion is still in the toolkit.
Yes, acknowledging that open conversion remains an important tool in managing late complications. The guidelines also provide updated algorithms for routine follow-up imaging after EVAR, which is outlined conceptually in Figure 6. And they offer a suggested diagnostic step-up algorithm for cases where you suspect an endoleak but non-invasive imaging is unclear. This step-up is shown conceptually in Figure 7.
And Figure 7 explicitly includes converting to open surgical repair with stent graft explantation as the ultimate option for refractory endoleaks where you can't determine or fix the cause minimally invasively.
It does, reinforcing that open surgery, though less common for primary repair, is still essential for complex long-term issues. A crucial point the guidelines make is that imaging follow-up after EVAR is only truly beneficial if you have the intention and ability to treat complications electively. Surveillance should be considered for discontinuation in very elderly, frail, or dependent individuals who are not candidates for secondary intervention, as imaging without the possibility of treatment is not helpful.
That's a key point for managing follow-up burden-only image if it will change management. Makes perfect sense.
Exactly. Finally, diagnostic angiography, while a gold standard, is usually reserved for cases where non-invasive imaging, CT ultrasound, is inconclusive about an endoleak or other complication.
Okay, that gives us a comprehensive picture of long-term follow-up and managing complications after repair, especially endoleaks. Let's move to Section 8. Beyond standard AAA tackling complex and rare presentations, this is where the anatomy gets really challenging, right?
Indeed. Complex abdominal aortic aneurysms are defined as those involving the renovisceral segment of the aorta, essentially. Aneurysms that are close to, or involve, the origins of the renal and visceral arteries, like the superior mesenteric artery celiac axis. The guidelines categorize these based on their relationship to these crucial branch vessels: short neck infrarenal, juxtarenal, pararenal, paravisceral, and type 4V thoracoabdominal aortic aneurysms. This anatomical relationship is visually represented and explained conceptually in Figure 8 of the guidelines.
So understanding the precise anatomical relationship to those branch vessels is key to defining complexity and planning repair. What about open surgical repair for these complex aneurysms? How risky is it?
Open repair for complex abdominal aortic aneurysms generally carries a higher perioperative risk compared to standard infrarenal repair, because it usually requires clamping the aorta above the renal arteries or even higher. The guidelines note that clamping above the coiliac artery should be avoided if possible due to increased ischemia risk. Benchmarks from reviews and registries suggest 30-day mortality rates are around 4% for open juxtarenal or pararenal repair, with renal complications occurring in 12 to 20% of patients and 1 to 3% requiring permanent dialysis.
Those are significantly higher risks than standard infrarenal open repair, no question.
They are. For endovascular management of complex aneurysms, fenestrated and branched EVAR, or FB-EVAR, is the primary approach. There are device-specific contraindications, but the general technique involves using a custom-made or specific stent graft that has openings called fenestrations or tubes called branches sewn into the main graft body. Fenestrations are used when the aortic branch artery origin is very close to the aortic wall, like often seen in juxtarenal or perirenal aneurysms, requiring precise alignment with the branch. Branches are used when the branch artery is further away from the aortic wall, allowing for a bridging stent to connect the branch vessel to the graft branch, like often needed for the visceral vessels in type 4 thoracoabdominal aneurysms. Scallops, which are simple cutouts, can also be used for vessels that don't need precise alignment.
Okay, so fenestrations for close branches, branches for further away ones. And how do outcomes look for FB-EVAR? Is it durable?
Outcomes show acceptable technical success and durability with established devices, but they do come with significant reintervention rates reported between 24 and 39%, and up to 41% at 5 years in some large registries. Importantly, most of these reinterventions are relatively minor, percutaneous procedures like fixing bridging stent issues or endoleaks, rather than major open surgery.
So they often work initially but require frequent minor tune-ups. That's the trade-off, maybe.
Yes, that seems to be the pattern. Results from pivotal trials like the Zenith trial for EVAR in juxtarenal aneurysms show good early outcomes, low 30-day mortality, and high freedom from aneurysm-related mortality, but higher rates of reintervention. The guidelines reiterate that completely new, unproven techniques in this complex space, beyond established FB-EVAR platforms, remain Class 3 recommendations and should be limited to clinical trials, as per Recommendation 123.
Class 3. Trials only, for unproven complex techniques. Sticking with established FB-EVAR systems is recommended if an endovascular approach is chosen. What about the risk of spinal cord ischemia, or SCI, after complex EVAR, especially for thoracoabdominal extent? That's a big worry.
This is a major concern, particularly when covering long segments of the aorta, interrupting blood supply to the spinal cord from collateral vessels. The guidelines list various prevention strategies: staging the procedure over multiple sessions to allow collateral development, maintaining high blood pressure and oxygenation during and after the procedure, preserving critical collateral arteries whenever possible, considering cerebrospinal fluid or CSF drainage, and using neuromonitoring during the procedure.
There seems to be some debate around the routine use of prophylactic CSF drainage, though. Is it clearly beneficial?
There is debate. Prophylactic CSF drainage has shown benefit in reducing spinal cord ischemia rates in randomized trials of open thoracoabdominal aortic aneurysm repair. However, the evidence for its routine use in complex endovascular aortic repair is less clear. You also have to balance the potential benefit against the risks associated with the drain itself, which were reported in 12% of patients in one study, with 2% leading to disabling complications. So the decision is nuanced and often individualized.
Okay, the role of prophylactic CSF drainage in complex EVAR isn't fully settled then. Needs careful thought.
Correct. Moving to managing ruptured complex abdominal aortic aneurysms.
That sounds like a truly dire situation. What do the guidelines suggest?
It is. There's a significant lack of high-level evidence guiding management in this acute, complex setting. The guidelines emphasize that an individualized approach based on available resources, anatomy, and patient status is necessary. Recommendation 129 is changed. For patients with a ruptured complex abdominal aortic aneurysm, open surgical repair or endovascular repair with off-the-shelf branched stent graft, physician-modified endograft, in situ fenestrations or parallel grafts should be considered based on patient status, anatomy, and patient preferences. This carries a Class 2B recommendation based on Level C evidence.
Class 2B, Level C, should be considered. But importantly, the wording explicitly includes options like using off-the-shelf branch grafts, physician-modified grafts, creating fenestrations in situ, or using parallel grafts like chimney or periscope grafts. That sounds quite permissive.
Yes. This reflects the reality that in a crisis scenario, like a ruptured complex aneurysm, where immediate mortality is extremely high, less proven or off-label techniques might be employed pragmatically if they offer the only feasible rapid solution, weighing the uncertainty of the technique against the certainty of death without intervention.
Pragmatism in an emergency. What about managing complications specific to complex EVAR after repair, like issues with the bridging stents going to the branch vessels? Any guidance there?
Recommendation 132 is new. Patients deemed at risk of bridging stent patency failure after endovascular treatment for complex abdominal aortic aneurysm may be considered for dual antiplatelet therapy in the early postoperative period. This is a Class 2B recommendation based on Level C evidence reflecting expert consensus.
Class 2B Level C consensus. May be considered for dual antiplatelets in those at risk of the small stents going to the branches clotting off.
Yes, and if a target vessel does get obstructed, prompt evaluation is critical. Recommendation 133 is new. Patients with target vessel obstruction after complex abdominal aortic aneurysm repair should be considered for prompt evaluation for possible revascularization. This is a Class 2A recommendation based on Level C evidence.
Class 2A, Level C, should be considered. If a renal or visceral artery is blocked after the repair, evaluate it quickly for potential revascularization. Good point.
Precisely.
Let's briefly touch on isolated iliac artery aneurysms, or IAAs. How common are these?
Isolated iliac artery aneurysms are less common than abdominal aortic aneurysms. They most frequently occur in the common iliac artery. They are often asymptomatic but can cause symptoms from compressing adjacent structures in the pelvis. Rupture is rare when they are small, typically below 40 millimeters, but the mean diameter at rupture is significantly larger, around 58 millimeters.
So surveillance intervals are based on size, similar to AAAs.
Yes, although high-level evidence is limited. Based on available data, recent recommendations suggest surveillance every 3 years for aneurysms between 20 and 25 millimeters, every 2 years for 25 to 29 millimeters, and annually for 30 millimeters or larger. Ultrasound is the preferred imaging for surveillance, with CTA used for larger aneurysms or when ultrasound is difficult.
And for management, open surgery versus endovascular, which is preferred.
Iliac artery aneurysms, particularly those involving the internal iliac artery due to its pelvic location, can be technically challenging for both approaches. However, meta-analytical data suggests lower 30-day mortality rates with endovascular techniques compared to open surgical repair for isolated iliac aneurysms, 2.8%, 8.2%.
Lower mortality with the endovascular approach for isolated iliac aneurysms. Okay, let's discuss mycotic abdominal aortic aneurysms, or MAA. Note this is different from iliac artery aneurysms, IAA. Easy to confuse.
Absolutely. Two completely different pathologies, unfortunately sharing a similar abbreviation sometimes. Mycotic abdominal aortic aneurysms are thankfully rare, often affecting younger patients compared to degenerative aneurysms. They are caused by infection of the aortic wall and have an unpredictable, aggressive, and malignant natural course characterized by rapid expansion, high risk of rupture, and death if not treated promptly.
Given that aggressive course, is size relevant for deciding to intervene? Or do you just treat them?
No, size is generally not the main factor. Due to the high risk of rapid expansion and rupture, studies show up to 44% present, with rupture prompt surgical or endovascular repair should be considered irrespective of aneurysm size. Diagnosis relies on a combination of clinical findings like pain, fever, signs of sepsis, laboratory markers, elevated inflammatory markers, and characteristic radiological features. Table 23 in the guidelines outlines conceptual diagnostic criteria, often including a saccular shape, rapid growth on serial imaging, or imaging signs suggesting infection like surrounding soft tissue stranding.
So if you suspect a mycotic aneurysm, treat it, don't wait for size. What's the recommendation for managing these? Where should they be treated?
Recommendation 142 is new. Patients with mycotic abdominal aortic aneurysms are recommended to be referred to high-volume vascular surgical centers for multidisciplinary management. This is a strong Class 1 recommendation based on Level C evidence, reflecting expert consensus on the need for specialized care.
Class 1, Level C, consensus. Refer to high-volume centers with multidisciplinary teams for mycotic aneurysms. Important point.
Yes. The choice of surgical technique, open or endovascular, should be considered based on individual patient status, the extent and location of the infection, and the patient's anatomy. This is recommendation 143, unchanged, Class 2A, Level C.
Class 2A, Level C. Individualized approach for technique in mycotic cases. What about inflammatory abdominal aortic aneurysms, or IAA? Again, distinct from iliac artery aneurysms. What are the key features?
Yes, completely different conditions. Inflammatory abdominal aortic aneurysms are thought to have an autoimmune basis. They are characterized by dramatic thickening of the aneurysm wall, extensive perianeurysmal and retroperitoneal fibrosis, and dense adhesions to surrounding structures, frequently leading to obstruction of the ureters and hydronephrosis. They can be associated with systemic conditions like IgG4-related disease, which can affect other organs but is typically associated with a lower rupture risk for the aneurysm itself.
And how do patients typically present? What's the classic picture?
The classic clinical triad includes chronic abdominal, back, flank, or pelvic pain, unexplained weight loss, and elevated systemic inflammatory markers like C-reactive protein and erythrocyte sedimentation rate. Hydronephrosis due to ureteral obstruction is a very common associated finding.
How do you follow these patients, particularly the inflammatory aspect? Are inflammatory markers reliable, or do you need imaging?
Interestingly, acute phase reactants alone are often not reliable indicators of the disease's inflammatory activity during follow-up. Their normalization doesn't necessarily mean the inflammation is resolved. Positron emission tomography, or PET imaging, specifically with 18F FDG tracer, may be helpful. Higher metabolic activity on a P-scan can correlate with the likelihood of responding to medical therapy like steroids and might help guide treatment decisions.
Using PET imaging to guide medical therapy, that's interesting. What's the risk of rupture for inflammatory aneurysms compared to degenerative ones? Is it lower?
The reported rupture risk for inflammatory abdominal aortic aneurysms is generally low, typically less than 5%. For this reason, the diameter threshold for considering repair is the same as for degenerative abdominal aortic aneurysms. Surgery is rarely needed simply to control the inflammation itself if it's refractory to medical treatment.
So treat based on size threshold, like degenerative aneurysms, unless there are complications specifically related to the inflammation that medical therapy can't control. What about the repair technique, open versus endovascular? Which is better?
Open surgical repair of inflammatory aneurysms can be extremely challenging due to the dense fibrosis, adhesions, and distorted anatomy. If the patient's anatomy is suitable for endovascular repair, EVAR is generally preferred. Studies show lower 30-day mortality rates and fewer major complications with EVAR compared to open repair in this specific group. However, the resolution of the perianeurysmal fibrosis after EVAR might be slower compared to after open repair, and the hydronephrosis due to ureteral obstruction might persist or even develop after EVAR, potentially requiring long-term management with double J ureteral stenting, as it's not clear that EVAR alone consistently resolves the obstruction.
So EVAR is preferred if anatomically possible due to lower paraprocedural risk, but be aware that the inflammation and associated issues like hydronephrosis might linger and need separate management.
Okay.
Precisely.
What about other even rarer pathologies that can affect the aorta, like isolated abdominal aortic dissections, intramural hematoma, penetrating aortic ulcers, pseudoaneurysms, and saccular aneurysms? That's quite a list. Yes, they are a mixed group of distinct pathologies, often more focal abnormalities of the aortic wall, rather than the classic generalized fusiform dilatation of a degenerative aneurysm. Figure 12 in the guidelines provides visual descriptions of their appearances. Isolated abdominal aortic dissections involve a tear in the inner lining, creating a false channel. Intramural hematoma is bleeding within the aortic wall layers without a clear tear. Penetrating aortic ulcers are erosions that penetrate through the inner lining deep into the wall. Pseudoaneurysms are contained ruptures where blood is held by surrounding tissues, not involving all layers of the aortic wall. And saccular aneurysms are focal, pouch-like outpouchings from the wall, unlike the usual spindle shape of a fusiform aneurysm.
And how are these typically managed? Are they easier to fix with EVAR?
Because of their relatively focal nature, these pathologies are often amenable to endovascular repair using stent grafts. This approach typically achieves high technical success rates. However, despite successful repair, these patients often have a high in-hospital mortality rate, reported around 10% in pooled data. This high mortality is primarily attributable not to the difficulty of the procedure itself, but to the underlying frailty and significant comorbidities of the affected patients.
So the procedure might be technically successful, but the patients themselves are often very high risk due to their overall health status. Let's discuss the scenario of managing concomitant abdominal aortic aneurysm and neoplasm when a patient has both an abdominal aortic aneurysm and a cancer. How do you prioritize?
This requires careful staging and prioritization. The fundamental principle is to address the most immediately threatening condition first. This could be a large, high-risk abdominal aortic aneurysm poised to rupture, or an obstructing, bleeding, or rapidly progressive cancer.
How do the treatment strategies generally compare in that situation? EVAR first, open first, both together.
If the abdominal aortic aneurysm's anatomy is suitable for endovascular repair, the preferred approach is often to perform EVAR first, followed by staged cancer surgery relatively quickly, typically within 2 weeks. This strategy minimizes the delay in addressing both serious conditions and, importantly, reduces the risk of the aortic graft becoming infected, which is a significant concern if major abdominal surgery is performed near an aortic graft. Studies have shown higher mortality and morbidity rates when open abdominal aortic aneurysm repair is performed before major gastrointestinal cancer resection, especially if there is a significant delay before the cancer surgery. If both the aneurysm and the cancer are considered immediately life-threatening and the aneurysm anatomy isn't suitable for endovascular repair, or in select younger patients, a synchronous open approach fixing both in one operation can be considered. However, this carries a higher cumulative morbidity and mortality risk compared to staged procedures. The guidelines note that overall long-term survival in these patients is often dictated primarily by the progression of the cancer, not the aneurysm management itself.
So, staged EVAR followed by cancer surgery is generally preferred if possible. Finally, what about abdominal aortic aneurysms in patients with suspected genetic diseases, particularly connective tissue disorders like vascular Ehlers-Danlos syndrome or VEDS? That must be very different.
Genetic conditions, especially VEDS, require a significantly different approach to management. Early genetic counseling and testing are strongly emphasized, not just for the patient but for their family members as well, due to the inherited nature of these disorders. VEDS is a serious condition characterized by fragile blood vessel tissue, which puts patients at a high risk of spontaneous arterial dissection and rupture, even at relatively small aneurysm sizes.
Are there specific medical treatments for VEDS that can help?
Yes, this is important. The beta blocker medication celiprolol has shown a significant benefit in reducing the risk of arterial rupture in patients with VES based on evidence from a randomized controlled trial and retrospective studies.
That's a crucial insight, a specific medical therapy that can directly impact rupture risk in this high-risk genetic group.
It is. However, it's critical to recognize that invasive procedures, both open and endovascular, carry higher risks in VEDS patients due to the tissue friability. These patients are best managed by multidisciplinary teams in specialized tertiary centers with expertise in genetic connective tissue disorders, including genetic family assessment and counseling.
So prompt genetic assessment, consider celiprolol, and manage these complex patients in specialized centers with a team approach.
Precisely.
Wow. We have really covered an immense amount of detail, from the basic service standards all the way through managing these incredibly challenging, rare pathologies. It's a lot to take in.
It's a testament to the comprehensive nature of these guidelines, attempting to cover the full spectrum of abdominal aorto-iliac artery aneurysm management.
Absolutely. And one of the things I appreciate most is that despite integrating all this new data, the guidelines are very transparent about where the evidence is still weak, where the uncertainties lie, and what we still don't know.
That transparency is vital. Navigating clinical guidelines effectively requires understanding not just the specific recommendations themselves, but also the strength of the evidence supporting them, recognizing that many are based on lower-level evidence or consensus, and being aware of the significant areas where more research is still desperately needed.
It highlights that our knowledge base is still evolving in many areas, even with the progress made.
Indeed.
Let's wrap up by looking at Section 9, the patient perspective and the unresolved issues identified by the Guideline Committee. Bringing it back to the patient is always key, isn't it?
It is. A core objective highlighted by the guidelines is to improve shared decision-making, or SDM. This involves providing high-quality, unbiased, evidence-based information about all relevant treatment options, including no treatment to the patient in a way they can understand. It requires a balanced discussion of the risks, benefits, and potential consequences of each option, and critically, truly incorporating the patient's individual preferences, needs, values, and goals into the final decision. The inclusion of patient representatives in the guideline development and in drafting patient information materials is a positive step towards this.
SDM is paramount, especially given the uncertainties and trade-offs we've discussed. And as you mentioned, the guidelines are very upfront about the knowledge gaps. What are some of the key unresolved issues the committee identified as needing further research? Where are the big questions still?
They list several critical areas for future investigation. Some general issues include the generalizability of the existing evidence. Most studies come from Europe and North America, and the evidence is heavily male-dominated, meaning we have insufficient high-quality data specific to women, which limits our ability to apply guidelines confidently across populations.
That's a significant limitation for applying these guidelines globally and to female patients. Really important.
It is. Another major overarching issue is the persistent lack of high-quality Level A evidence in many areas of aortic disease management. As we saw, 70% of recommendations are Level C or consensus. This makes interpretation challenging due to potential biases inherent in lower-level evidence, like single-center bias or the influence of industry funding, underlining the urgent need for more unbiased, high-quality trials.
So even with all those new references, many fundamental questions still lack robust answers.
Exactly. For screening, they mention the need to better evaluate the full impact of combining abdominal aortic aneurysm screening with secondary cardiovascular disease prevention efforts. Also, the debate and variability surrounding ultrasound caliper measurement for small aneurysms persist, with no clear consensus on the best method despite its significant impact on diagnosis and management decisions. That needs sorting out.
And for cardiovascular risk management in these patients, specific targets.
They highlight the need for more research to define abdominal aortic aneurysm specific optimal LDL cholesterol target values and optimal blood pressure limits. Also, the precise risk-benefit ratio for prescribing platelet inhibitors specifically to abdominal aortic aneurysm patients for growth reduction or other benefits, beyond their role in general cardiovascular prevention, still needs clarification.
Specific targets and medication benefits need more clarity. What about unresolved issues regarding complex aneurysms, those juxtarenal ones and so on?
Here, the indications for repair are less clear for aneurysms in the juxtarenal, pararenal, or type 4V thoracoabdominal segments compared to simple infrarenal ones. The assumed higher rupture risk for these complex aneurysms isn't as well demonstrated, while the operative risk is generally higher. Better evidence is needed to truly support decision-making on when to intervene in this complex anatomical space.
And for the endovascular techniques used for complex cases, off-label use, durability.
The long-term role and durability of off-label endovascular solutions remain significant questions requiring more evidence. There's a desire to move towards universal, durable, off-the-shelf stent graft solutions for elective complex cases to replace time-consuming and expensive custom-made devices, but this requires significant device development and rigorous testing.
Cost-effectiveness, particularly for complex endovascular repair with custom devices, is also an open question, I imagine.
Yes, it's recognized as an area needing further study. And they note the need for more research to understand why some studies have reported poorer long-term survival after fenestrated EVA compared to open repair. Is it purely due to patient selection bias? Or are there unrecognized adverse long-term effects of the procedure or device that we need to understand better?
For isolated iliac aneurysms, are there specific unknowns, like location?
Yes. The guidelines treat iliac aneurysms somewhat as a single entity, but it's plausible that the risk of rupture differs significantly depending on whether the aneurysm is in the common iliac, external iliac, or internal iliac artery. This anatomical nuance and its impact on risk needs further clarification.
And finally, for the rare pathologies like mycotic, inflammatory, or focal aortic lesions, what's needed there?
For conditions like mycotic aneurysms, inflammatory aneurysms, penetrating aortic ulcers, intramural hematomas, pseudoaneurysms, saccular aneurysms, and isolated dissections, the guidelines strongly call for the establishment of international registries. These are crucial to gather enough data to better understand their true epidemiology, evaluate the effectiveness of different medical treatments, refine the indications for surgical or endovascular intervention, improve surveillance strategies in patients with genetic disorders predisposing to these issues, and compare outcomes after both open and endovascular repair. Specific unknowns here include refining patient selection criteria for endovascular management of mycotic aneurysms, determining the truly optimal medical and operative strategies for inflammatory aneurysms, and understanding the natural history and rupture risks specifically for saccular aneurysms.
That's a substantial list of unanswered questions, isn't it? It really highlights how much frontier there still is in this field, despite the depth of these guidelines.
It does, and these unresolved issues serve as a roadmap for future research directions that will shape the next iteration of these guidelines.
Well, we have certainly taken a comprehensive deep dive into the 2024 ESVS Abdominal Aorto-Iliac Artery Aneurysm Guidelines. It's clear they represent a monumental effort to synthesize the latest evidence, but they're also incredibly valuable for their transparency in highlighting where that evidence is weak and where the major unknowns still lie.
Absolutely. Navigating these guidelines effectively in clinical practice means not just knowing the recommendations, but understanding the strength of the evidence behind each one, recognizing the limitations, and being aware of the significant areas of uncertainty and the unresolved issues that should prompt careful consideration and potentially referral or inclusion in studies.
It's a field that's constantly evolving, and these guidelines give us the current best roadmap while pointing towards where we still need to explore. So here's a final provocative thought for you, the listener, to consider as you integrate these updates into your practice. Given the persistent challenges in obtaining high-quality Level A evidence in many areas of aortic disease management, particularly for complex or rare presentations, how do you personally weigh and integrate strong, evidence-based Class 1 recommendations with consensus-based Class 2A or 2B recommendations in your daily clinical decision-making? And how do you effectively communicate this inherent nuance, this blend of certainty and uncertainty to your patients when engaging in shared decision-making? Something to think about. Thank you for joining us for this deep dive into the 2024 ESVS Abdominal Aorto-Iliac Artery Aneurysm Guidelines. We hope this exploration helps you navigate the complexities and apply the key insights in your practice. Keep exploring, keep questioning, and keep learning.